Hi, Adult Health One. So this is Module 6B. We're going to talk about electrolytes from Chapter 8 and then just touch on some acid-base balance from Chapter 9. We are going to go over ABGs, how to interpret ABGs, and all of that as part of lab. Okay, so we're just going to talk about with acid-base balance, we're just going to talk about why we care, basically how it can affect the body, what disease processes, and then what as nurses we would expect to do about it. Also with the electrolytes, there's a lot of information. The electrolytes all start to sound the same. So when you are, and we'll talk about this in class as well, but when you're trying to differentiate your electrolytes, um, you want to think about which ones work inversely to each other, which ones work together. Sodium and chloride work the same for the most part. There's very little differential. So you want to key in on which ones are similar and then which ones, like what stands out and sets them apart, okay? Here are our objectives. All right. So fluids and electrolytes exist within the body. They're dynamic in nature, meaning, it's moving back and forth. The whole point is to maintain balance or homeostasis, right? So our electrolytes are responsible for chemical reactions that produce energy. Don't forget that electrolytes are electrically charged, right? We have positives and we have negatives. Um, and they have that electrical charge when they are dissolved in water. So remember yesterday we talked about the female body's 55% fluid and the male body's 65% fluid. So these electrolytes are flowing around in fluid and they're electrically charged, right? And they are providing energy to us. Um, there's a whole bunch of, this is just straight out of the book. If you read the speaker notes, just talking about, positive versus negative charges, that's not really a whole lot of concern to us. But as nurses, we need to recognize alterations in electrolyte balance and then seek corrective interventions. Because again, although the physician is the one who's going to be writing the orders, we're the ones spending 12 hours with the patient, right? So we're going to have a better feel of what signs and symptoms they may be experiencing. We're going to start with sodium because sodium is the major cation in the ECF. That's extracellular fluid, right? So that's the stuff floating in between the vascular space and the cells. So like interstitial, remember that's the same thing, interstitial and plasma. So the deal with sodium is its whole function is to regulate fluid volume. When sodium is reabsorbed in the kidneys, water and potassium are also reabsorbed, thereby maintaining ECF volume. So sodium works with potassium, all right? Remember our sodium potassium pumps? It's that back and forth. Always keep in mind, for the most part, where sodium goes, water's going to want to go, right? They're attracted to each other. So if we have an excess of sodium, it is likely that we have an excess of fluid. Now, the consideration with that is, let's say I have a dehydrated state where dehydration just refers to the fluid part. So you may have hypernatremia related to the fact that you have perspired out, peed out, gotten rid of all this fluid, and this sodium got left behind. All right. So there's two ways to think about it. And in yesterday's lecture, we talked about things being falsely elevated. That's where that comes into play, right? I have the same number of particles potentially, but it's concentrated in less fluid. So it seems like I might have a hypernatremic state. Okay. All right, so sodium levels are controlled by thirst ADH, the RAS, which we all talked about yesterday. Um, Excessive free water intake and release of ADH can result in low serum sodium levels. Basically, we've diluted the concentration. Sodium potassium pump facilitates transfer of sodium from the ECF to the ICF and transfer of potassium from the ICF to the ECF. Remember, that's just the sodium potassium pumps back and forth, maintaining homeostasis. Um, let's see. All right. So hyponatremia. Remember when we have any hypo whatever state, our treatment is going to be replacement, right? If I have too little salt, I'm going to replace it with salt, right? So, which makes sense. So any of your hypo states, replacement, all right? So hyponatremia is the most common electrolyte disorder. Um, it represents the amount of water in relationship to the serum sodium, okay? So hyponatremia is often related to the fact that we have lost fluid, and in losing fluid, we have lost salt. So disturbance in water balance, right? Um, I'm looking through these notes. I just don't want this to get too long and too confusing. Let's see. So don't forget when we are talking about things that affect fluid balance in the body, diuretics play a role in that. And a lot of patients are going to be on diuretics, especially in med surg, right? So we need to know what diuretic our person is on, what area of the kidney it is affecting, how it is producing that extra fluid loss, because that's going to clue us in into what electrolyte may be affected. Okay, so loop diuretics and thiazides can cause hyponatremia because of sodium and water loss. All right. Um, Also, don't forget we can lose sodium if we have diarrhea, vomiting, hyperglycemic states actually with glycouria. So you're peeing out some of that to the point you're hyperglycemic to the point that your urine has sugar in it. And also perspiration, right? Sweat is salty. So if we're sweating a lot, like I always use the example of hiking Camelback in July at 2 p.m. If you're sweating a lot, you are going to deplete yourself of that sodium and you can be in a hyponatremic state. So we're going to see with hyponatremia, we're going to see weight loss, that orthostatic hypotension, tachycardia, um, signs and symptoms, other signs and symptoms, headache, lethargy, confusion. If your sodium drops below 120, we worry about seizure, coma, death. All right. So when somebody comes in and they're severely dehydrated, that is our biggest worry with related to hyponatremia, is that if it is below 120, seizure, coma, death. All right, it is a problem. So we always want to be looking for our neuro signs and symptoms. Okay, and that's really the biggest thing. And also, when we are replacing things, we want to go slowly with replacement if possible, because don't forget that as we're replacing things, things are moving back and forth, right? So if we just slam in 5 liters of normal saline, or maybe even, a hypertonic solution like 3% or 5% normal saline, we're going to cause massive fluid shifts and it can be detrimental to our person. And we talked about that yesterday as well. So, and then of course, anytime we have a hypo whatever state, our worry is always tipping to the hyper state. Okay, just like when we talked about hyper and hypovolemia, we always worry about tipping to the other degree. This is a table, this is table 8.8. This talks about hyponatremia and what are our causes, hypervolemic versus hypovolemic, because really you can have either one. Um, so this is just an FYI, and that's table 8.8, slide 6. Hyponatremia nursing considerations. So because salt is so tied to water, we of course think about daily weights and I's and O's, neuro changes. One of the things you're going to see with hyponatremia that sets it apart is like muscle twitching, okay? Lethargy, seizures. Sodium deficit, if sodium deficit is suspected, we're going to look at that urine osmolality, specific gravity, signs, patient teaching, what to look for, what are the signs and symptoms of hyponatremia, and then salt replacement via food. That's probably one of the easiest ways, like we talked about yesterday. If we can replace fluid, we prefer like the PO route, right? So with any of these, we prefer PO. Not that that's always possible, but we do prefer that. And then as nurses, we're going to look for those decreased levels of consciousness, any changes in mentation, because we worry about that neuro status change, okay? Hypernatremia. So this too can be related to direct water loss. This is most often when we see hypernatremia, to be honest, and that means that we had some sort of uh, fast, quick fluid loss, and the salt got left behind. All right. Our signs and symptoms: neuro again, irritability, agitation. The skin's gonna get flushed. We're going to have tachycardia, decreased urine output, right? Orthostatic hypotension again. And that is related to the hypovolemia. So our treatment is we are going to try to add fluid, but just fluid. We're not going to be adding a lot of salt. So you can use like 1/2 NS or your D5W. Right, D5W, that is 5% dextrose and water. So that's just sugar. Remember, dextrose is just our sugar. Half NS. We're going to be putting more fluid back in than sodium. All right. Complications greater than 152, seizures, coma, death. All right. So seizures, coma, death are a thing, period, with too little or too much salt. We always worry about that. And we worry about those changes in mental status. I'm just looking through the talking points here. So clinical manifestations, non-specific neuro changes, really that agitation, restlessness. They may complain of thirst, right? Because they have too much salt. Uh, the body is telling the body that the concentration is off, right? Medical management, 1/2 NS, D5W possibly. Let's see. That's pretty much it. And my barking dog in the background. Perfect. So nursing considerations. So close monitoring, right? We want to have early recognition of patients at risk for hypernatremia. We're going to be watching those I's and O's. We specifically want to pay attention to people. Maybe they're on enteral feedings. Maybe they can't access water on their own. So dementia, advanced age, stuff like that. We want to make sure that people are hydrating adequately. So we're going to, when you do enteral feedings and whatnot, you can add free water, is also possible. You can add a flush or a bolus of free water. So again, daily weights, right? Weight is the best non-invasive indicator of fluid status. And when we're talking sodium, we're also talking fluid status. Um, if you have somebody with diabetes insipidus, that is a brain disorder, and the brain forgets to tell the body to hold on to urine. So the problem with diabetes insipidus is your person is peeing just like all the time. So they can get easily dehydrated and leave that sodium behind. So we give desmopressin for diabetes insipidus, but you really have to be monitoring your eyes and O's. Like that's an hourly, not just like a end or mid shift sort of thing. This is a safety alert. This talks about with the acute onset of sodium's levels less than 120, like we talked about. We worry about the brain swelling and intracranial hypertension, and obviously uh, coma, death, right? Not good. This is box 8.1. This is some of the sodium content of common foods. It's just sort of an interesting little list. I think some of the surprising ones on here were maybe like tomato soup, has really high sodium, tomato juice, um, even frozen veggies. Well, they're not too bad, but it just kind of gives you a little breakdown. Some interesting things on there. That's slide 11. This talks about, this slide 12, talks about our hypo and hypernatremia. So it compares them right next to each other. All right. All right, now we're going to talk about potassium. I want you to, this is slide 13, box 8.2 in your book. There's a list of potassium content of common foods. These you want to be a little familiar with, like at least the first five, right? 98% of potassium is found in cells. Remember the sodium potassium pump that controls the movement of potassium into and out of the cells. Potassium helps with neuromuscular function. All right. Potassium's role just as important as sodium's related to thermogenesis and transport. All right. So, and then 80% of daily loss of potassium occurs through the kidneys. So that is important to keep in your brain, because if my kidneys are not functioning correctly, is my potassium functioning correctly? Really possibly not, right? So a lot of times patients, because of disease processes, end up with like acute kidney injury, AKI, and we need to be thinking about our potassium, because again, if our kidneys are not functioning properly, like possibly our potassium is going to be off. All right. Looking through these notes here, that's good. So hypokalemia. All right. Remember, you guys do not have to memorize these values. They will be on NCLEX for you, and they will be on the exam that you take with us. All right. So you don't have to memorize values anymore. Part of that is because values can be different from facility to facility and textbook to textbook sometimes when you read different things. So it's not hard and fast, but it's going to be similar. All right. So hypokalemia, we have mild, moderate, and severe. Um, let's see. Potassium deficit can occur secondary to losses through the GI tract and renal system, due to actions of meds, transcellular shifts, or inadequate intake of potassium. Diarrhea, vomiting, gastric suctioning can really affect our potassium. Um, Metabolic alkalosis, excretion of potassium. Significant potassium loss can occur as a result of the loss of gastric secretions and then as a result of renal excretion of potassium to correct metabolic alkalosis from the gastric secretion loss associated with the loss of hydrochloric acid. So all of that is all that's saying, that's kind of huge. Nasogastric suctioning, right? What's in our stomach? Acid. There's acid in our stomach. So if we are using nasogastric suctioning, um, to help decompress the stomach or whatever is going on. We are pulling out acid. When we pull out acid, we throw the body into a state of alkalosis. So I'm going to explain that more with ABGs, all right? But just be aware that nasogastric suctioning can be a problem because I'm pulling out that stomach acid, all right? And with that, I'm pulling out electrolytes. So I can cause myself a hypokalemic state. Signs and symptoms may be cardiac, pulmonary, neuromuscular, and GI. So potassium affects a lot, right? We're going to see weakness and lethargy, hyporeflexia. So your muscles are tired. They don't respond as quickly. Signs and symptoms can be related to constipation. Nausea, vomiting, abdominal cramping can be a sign or symptom. And we can see an EKG change with, in particular, ST depression. All right. Replacement, we're going to give PO or IV. We never push potassium. Potassium works on the heart. So with potassium, those EKG changes are really important because you can kill someone if you push potassium related to the dysrhythmia that you cause. So complications of hypokalemia, muscle weakness, cramping, cardiac dysrhythmias, you cannot underestimate that one. And again, somebody could die. So this is a safety alert, slide 15. Administration of IV potassium is considered a high alert medication. Potassium is never to be administered as an IV push bolus. There's also total maximum 24-hour dose is 150 milliequivalents, and an infusion pump must be used when administering IV potassium. IV potassium, I can tell you too, burns. So you can't run it very fast, which you shouldn't run it very fast. But you can always slow down your potassium if it's burning on somebody. Hypokalemia nursing considerations. We are going to want to put this person on cardiac monitoring. All right. Anytime we're talking potassium, we worry about what it's doing to that heart. So cardiac monitoring. We want to make sure that we have IV access because if we need to emergently treat this person, if they code on us, we want to make sure we have access. We want to look at respiratory function because hypokalemia, our muscles can be weak, they're tired, they're not firing right? So we can have respiratory muscle weakness. If the body gets too tired to breathe or starts using accessory muscles, the body can give out, and then we're in a code situation. We're going to want to think leg cramps, muscle weakness, ventricular dysrhythmias. Medication alert here. If a patient is on digoxin, hypokalemia can potentiate the effects of DIG by increasing blood levels of digoxin. All right. So if we have low potassium and we're giving our DIG, it can actually, the body doesn't process the DIG the same. So you can end up with more DIG in the bloodstream than you would think. So you can end up to DIG toxicity. This is going to be loss of appetite, nausea, vomiting, dysrhythmias, and visual disturbances. Hyperkalemia, also categorized as mild, moderate, and severe. Again, this too can be related to renal failure, meds, in particular diuretics. Maybe this person eats spinach every meal of the day, all day long, right? So hyperkalemia, believe it or not, could be related to excessive intake of foods. Addison's disease, which is adrenal cortex insufficiency. We worry about hyperkalemia. Let's see. NSAIDs. NSAIDs can cause hyperkalemia related to renal insufficiency. It can play into that because the meds decrease the renin secretion. That's part of that whole RAS system, which we'll talk about. Um, Signs and symptoms: generalized fatigue, muscle cramps, palpitations, paresthesia, sorry. That's that tingling, right? Like pins and needles tingling. We really worry about cardiac arrest related to hyperkalemia because of the EKG changes that we see. So our nursing considerations: monitoring and reporting elevations in the BUN and creatinine, because that clues us into renal function. And don't forget, 80% of our potassium is lost through the renal system. So if our kidneys are not functioning correctly, we may be holding on to this potassium, which it may be too much for us. Serum glucose levels can be related to hyperkalemia. Acid-base status also. Patients with cardiac dysrhythmias and muscle weakness may have hyperkalemia. We're going to want to monitor that. Again, make sure your person is on cardiac monitoring. And then we're going to want to look at what meds our person is on, right? You know, are they on diuretics? Are they on potassium sparing diuretics in particular? We're going to want to see what's going on. Slide 19. So the top picture is a normal sinus rhythm, all right? Normal sinus rhythm. See how this is our QRS right here? Hopefully you can see my arrow. See how that's my tall point. My T is just kind of like a little mountain. My P is just a little mountain, all right? This is normal sinus rhythm. Slide 19. Now, here is a slide 20, about what happens in hypokalemia, first of all, and then hyperkalemia. So really, we're going to be looking at my T waves. So in hypokalemia, that T wave is inverted. See how that is pressing down, right? It's pressing down. It's inverted. This guy right here is a U wave, which you normally don't even see. It's usually absorbed, whatever. But the U wave is usually, you really don't even see a U wave normally. But with hypokalemia, potassium is down, T wave is down. Hyperkalemia, I have this tall, crazy, peaked T wave, all right? And then everything else is kind of spread all out. My P wave is flattened, my QRS is wide, right? It's further apart. So I have too much kalemia and I have too much of a T wave, okay? So just keep that in mind. This slide 21, compares hypokalemia to hyperkalemia, so that you can see that comparison right next to each other. All right, we're going to talk about calcium, foods high in calcium. One of the crazy things on there is like orange or grapefruit juice is 300 milligrams in 8 ounces, and that's the same as milk, which I thought was really interesting. Also, canned salmon with bones in particular, 210 milligrams. Broccoli's on there, soybeans, kale even. And then of course cheese and our dairy products, right? So calcium, it's positive cation, responsible for bone health and neuromuscular and cardiac function, essential factor in blood clotting. 99% of our calcium is in bones and teeth. So think about if somebody gets in, let's say an MVA, and they bust that femur, right? That femur is just complete clean break. We worry about calcium deposits getting into the blood because all of our calcium is in bones and teeth. So anytime you have something going on with your bones, you worry about how that is affecting your calcium. So, and you know, when we're talking bones and teeth, we always want to look at our calcium level, see where that's at. Because calcium is so vital for cardiac and muscle function, serum levels are tightly regulated by the body. regulation on the basis of function of the parathyroid and thyroid. So your parathyroid is responsible for releasing or not releasing calcium into the body. So calcium is positively charged, right? Um, so calcium really works on our muscles to keep our muscles working. When we have hypocalcemia, we are going to get one of the main signs and symptoms is Trousseau's and Chavostex. Chavostex is the cheek twitching, the what am I thinking of? Anyway, Chavostex, cheek twitching. Trousseau's is where you use a blood pressure cuff and you get a carpal spasm in the fingers, right? So when you think calcium, low calcium, think twitching of the muscles. Hypocalcemia needs calcium needs vitamin D. So if we have a vitamin D deficiency, we can have a calcium deficiency. Also, if our parathyroid is not working correctly, diarrhea, malnutrition, lactation, moms who are breastfeeding, right? That baby's taking all our things. So you can have a hypocalcemic state, even during pregnancy for the same reason. Bone disease, chronic alcohol abuse can affect your calcium levels as well. Are signs and symptoms. You're going to have it, it's going to depend on how rapid your hypocalcemic state is. You know, has this been ongoing and just getting worse, or is this something new? So calcium keeps our muscles in check, all right? It keeps them from twitching and spasming out on us. So if we have too little calcium, it's no longer keeping our muscles in check. So we're going to see excitability of nerves and muscles. You may have areas of numbness, muscle spasms, twitching, tingling, tremors, tetany, smooth muscle spasms, right? You may have dysphagia, wheezing, and bronchospasms. And again, calcium keeps the muscles in check. And if we have too little calcium, muscles are just twitching, doing all the things. Here's our positive Trousseau's and Chavostex. This is slide 24. Definitely take a look at these. And remember, Chavostex, cheek twitching, right? Tapping the nerve, right? Over the facial nerve, and you're going to end up with hyperexcitability, cheek, Chavostex. And I just remember Trousseau's is the other one, and the other one is the blood pressure cuff and the carpal spasm. So hypocalcemic RN considerations. We're going to monitor for patients who are at risk. Laryngeal stridor is possible with this, and that's not good because that can close down on us. So we're going to worry about listening for the sounds of stridor because our person may not be able to maintain their airway. You're going to have cardiac dysrhythmias because our heart is a muscle. So if I don't have enough calcium to keep my muscles in check, my heart may go a little crazy on me. You can also have seizures. You're going to want to keep emergency equipment, intubation equipment at the bedside, maybe your code cart, defibrillator, you're going to have all of that ready. Let's see. We want to keep our person calm, right? This person is in an irritated state. So related to too little calcium. So we want to keep a calm area. And then our education is going to be related to, foods that have high calcium. Stop smoking. That can actually cause urinary excretion of calcium. So you want to stop smoking. Limit intake of caffeine and alcohol because that affects intestinal absorption of calcium. So all of these things, basically make good health choices, right? Hypercalcemia. So hypercalcemia is usually related to malignancy or primary hyperparathyroidism. Um, Bone metastasis of secondary carcinomas, lymphoma, multiple myeloma, all of that stuff. So when you have a cancer affecting the bones, because obviously that's, anytime you have bone break apart, we worry about calcium, too much calcium getting into the blood system. So anything like that is going to affect that. Theophylline toxicity. Um, Lithium toxicity, thiazides, also calcium carbonate. Um, be aware of which meds can affect and cause hypercalcemia. So that's thiazide diuretics, lithium, calcium carbonate, which makes sense, and theophylline. We can end up with toxicity. You can read through all of those talking points on there. There's really nothing too crazy. Clinical manifestations related to hypercalcemia are related to how quickly, again, the state of hypercalcemia starts, right? Was this a slow progression, or were you in an MVA and your femur split in half and there was a rush of calcium into the bloodstream, right? So signs and symptoms, we may have bradycardia, hypertension, thirst, lethargy, muscle weakness, right? Um, because now calcium normally keeps things in check. Now we have too much, so it functions a little bit like magnesium that way. In that too much calcium, we're going to be lethargic, our muscles are going to be weak, right? We may have constipation because even the bowel is not going to be moving the way it should. You're going to have decreased deep tendon reflexes. um, and again, all of these signs and symptoms are dependent upon how hypercalcemic you are. Also, renal calculi, so kidney stones, a lot of times those are made up of calcium. So you can end up with kidney stones, renal calculi related to hypercalcemic levels. And then of course, what we worry about with renal calculi is obstruction. That's our biggest thing, not to even mention the pain that it causes people. So treatment, initial medical management dependent on the severity, right? And our goal is stabilization and reduction of calcium levels. Reduction of serum calcium is achieved through increased calcium excretion. And what we're going to try to do is get those bones to reabsorb some of that calcium. So we're going to discontinue meds that are associated with hypercalcemia. We're going to treat any underlying causes. Remember, a lot of this is usually related to malignancy, and hyperparathyroidism and, renal failure again. So we're going to want to treat those things to work on this situation. Fluid volume, if we need to replace fluid, we're usually going to use NS, normal NS. We're going to monitor those I's and O's. Whenever we have a hyper whatever situation, we may end up using dialysis, because dialysis goes in and pulls out all those toxins for us. Okay, so we may use dialysis. We're going to give IV bisphosphates. One of the things that we use, because IV bisphosphates inhibits bone reabsorption, or in the breakdown of bone and the release of calcium. So it's going to increase renal excretion of calcium. So IV bisphosphates is going to help our kidneys get rid of that calcium. The problem with IV bisphosphates is it takes about 2 days. Peak treatment is 7 days. So this is not going to happen immediately. So we need to be doing some things in between that also help. So we're also going to use some calcitonin. Calcitonin also works to increase renal excretion of calcium. So we give that IM or sub-Q, and that starts working within several hours. Okay, so we're going to use both. IV bisphosphates Bisphosphonates work a little longer. They work up to 7 days. Calcitonin starts working within a few hours, and it lasts several days, but not the full 7 like bisphosphonates. Complication, you can actually get a hypercalcemic crisis when those calcium levels are greater than 14. So we're going to see cardiac rhythm changes, um, stuff like that. Remember, all of these things are going to have some effect on the heart because the heart's a muscle. So all of these things are going to have some sort of EKG change related to them at some point, but really focus on potassium as the one we're concerned about with the heart. All right. All right. Uh, our our RN considerations: cardiac rhythm, mental status. We're going to want early and frequent ambulation if our person is at risk. We're not going to want them just sitting there. Remember, when we move the body, we keep everything functioning the way that it should. Also, adequate hydration is important. Here's our slide 28. This compares hypocalcemia to hypercalcemia. So that gives you your signs and symptoms and then how we're going to treat that. All right, mag. So mag is a mineral used in more than 300 biochemical reactions in the body. So only about 1% of mag is in the blood. The rest is between the ICF and bones, all right? Here's some food sources for mag. We always want to be aware of our food sources. So mag kind of works with calcium, all right? It alters the effects of calcium on the smooth muscle. Mag causes us to relax, right? So we take mag at night to help fall asleep. We take mag to help with muscle cramping. So magnesium helps that smooth muscle relax, all right? We need it. It's part of healthy bones, teeth, nerve, and muzzle. There we go. Nerve and muscle function and coagulation. It helps prevent myocardial infarction, stroke, any of our bone problems. So it's really, really important to good health. Hypomagnesium really magnesemia, sorry. We really see this related to malnutrition, and possibly excessive excretion of mag via the renal system. So there's those kidneys again, right? Hypokalemia and hypocalcemia can be present in patients with hypomagnesemia. So know that those three things can go together. So if I'm suspecting hypomagnesemia for whatever reason, and I know that hypokalemia and hypocalcemia can be present, I also want to be monitoring for those signs and symptoms, right? So calcium levels are affected by mag because of the dependence of the production of salicylic adenosine monophosphate on magnesium. You don't have to memorize this. Salicylic adenosine monophosphate controls the release of parathyroid hormones. Remember, parathyroid is responsible for our calcium. So the relationship of hypomagnesemia and hypokalemia, that was hypomagnesemia and hypocalcemia. Now, the relationship between hypomagnesemia and hypokalemia, not totally understood, but it's thought to play a role in impairing the sodium potassium ATPase, contributing to potassium wasting. So they're not really sure why low mag affects low low potassium, but they think it has to do with those sodium potassium pumps, okay? And then low mag affects low calcium because of its effect on the parathyroid. Hypomagnesium RN considerations. So we want to look for our patients who might be at risk. We're going to put them on cardiac monitoring. Now, again, these people may have muscle weakness as well. So we're going to want to be worried about fall and disorientation. Education is going to be talking about foods, use of laxatives. You don't want to, you know, with diarrhea, you can put yourself into hyper or hypo um, electrolyte states, and also alcohol abuse because of the way it affects absorption. Um, we are going to do IV replacement. We're going to watch the respiratory rate. And that's pretty much it. It's not too crazy. Again, with our hypos, we're gonna replace our stuff, right? So hypermagnesemia. Most common cause is over replacement, um, related to magnesium deficits. So we have tipped the scale to the other direction. It can also be related to renal insufficiency or renal failure, just like everything else. Because of the effective excretion of magnesium by the kidneys, hypermagnesemia is actually uncommon. All right, you're probably not going to see this. It's usually going to be related to um, over supplementing. So don't forget though that we do have meds that contain magnesium, like milk of magnesia. You don't really hear about that too often anymore, but that you can take that for upset stomachs. And then of course all of our mag replacements. Um, Older adults are at risk for hypermagnesemia because of decreased renal function, use of magnesium containing laxatives and antacids. Lithium toxicity can also result in hypermagnesemia because it decreases renal excretion of the mag. So our signs and symptoms, again, we're going to have cardiac, central nervous, respiratory, hematological systems. Cardiac symptoms include hypotension, because mag opens everything up, right? It relaxes things. So we're going to have vasodilation and dysrhythmias. We may have bradycardia, heart's a muscle, going to slow that muscle down, right? We could have AFib, which is interesting, um, and a widening QRS complex. Um, let's see. Our treatment is going to be aimed at the cause. What is causing our hypermagnesemia, right? So treatment aimed at the cause. So let's see. I just want to make sure. Let's see. I'm just looking through our treatments here. Aimed at the cause. All right. RN considerations. So clinical manifestations. Clinical manifestations, we're going to want to be monitoring vitals related to hypotension, EKG related to cardiac dysrhythmias. They're going to be on monitoring. Respiratory depression is possible with this because, again, too much mag, our muscles are going to be all languid and whatnot. Neuro assessments. We want to look for changes in level of consciousness, deep tendon reflexes. Loss of deep tendon reflexes occurs because of the blockage of synaptic transmission of nerve impulses that occurs when mag levels reach 6 to 10. So it's slowing everything down, right? Our older person, well, any of our people, we're going to teach them about mag-containing laxatives and antacids, and then, of course, high mag content foods, and checking your over-the-counter stuff. Here is a slide 34, that compares hypomagnesemia to hyper. Just kind of compare and contrast those things. All right, chloride. Chloride mimics sodium. Chloride is a salt as well. It very much mimics sodium. All right. So chloride is the most abundant anion in the ECF. It's usually bound with other ions, especially sodium or potassium. So, right, we have like sodium chloride, potassium chloride, right? It's usually hanging out with somebody. Chloride is found in pancreatic and gastric juices. It's also in saliva, sweat, and bile. Relationship between serum chloride and bicarb is an important indicator of the nature of acid-base disturbances because bicarb is the anion most often exchanged with chloride. So normal chloride levels are achieved through excretion and reabsorption of chloride in the kidneys, just like everything else. Hypochloremia. This can be related to severe vomiting, burns, respiratory acidosis, NG suctioning, metabolic alkalosis, which we're going to talk about, Addison's disease, maybe administration of IV fluids that didn't have any salt in them, like our dextrose solutions, or anything high in bicarb. Okay. So signs and symptoms, a lot like low sodium, irritability, hypotension, tetany, shallow respirations, hyperexcitability of muscles and nerves. Treatment, we're going to replace that chloride. Okay, we may give 1/2 or normal saline. Complications, you can have hypochloremia and hypokalemia. So mostly we're going to be looking at the signs and symptoms of hypokalemia, to be honest. Cardiac dysrhythmias, also our signs and symptoms are similar to hyponatremia. So if we get too low though, because it throws everything else off, you can have seizure, coma, death, right? So our nursing considerations, we're going to think changes in level of consciousness, respiratory effort, muscle control. And we want to let our physician know whenever we see any of these signs and symptoms. Patient education, ingest more salt foods, right? Go to McDonald's, get yourself some French fries, right? Um, Basically, that's going to help with reoccurrence. Hyperchloremia. Um, Also, again, similar to hypernatremia, like almost exactly the same. A salt is a salt, right? So similar to those observed in fluid volume excess, metabolic acidosis, hypernatremia, deep and rapid respirations, lethargy, tachypnea, decreased cognitive ability, and potentially elevated blood pressure. Now, that elevated blood pressure is going to be related to the fact that don't forget where we have lots of salt, a lot of times we have lots of fluid. So that elevated blood pressure is going to be related to the fact that we have too much fluid because it's hanging out with our too much salt. Okay, so treatment, treat the underlying cause. If this is acid base related, we're going to fix the acid base disorder. We're going to maybe get rid of some fluids, like going to use some Lasix. We're going to use 1/2 NS if we need a fluid. If we need to replace that fluid, if we have extreme fluid loss and we are hypochloremic because our electrolytes got left behind, then we're still going to use that 1/2 NS to replace the fluid, but not replace too much salt. Okay. Sodium bicarb infusion may be utilized because it's going to work to help with urinary excretion of chloride. Complications, cardiac dysrhythmias, decreased cardiac output, seizure, coma, death. Okay. Nursing considerations. So we're going to monitor for all the things, neuro, cardiac, respiratory. When chloride is off, something else is off. So you have to take into consideration those other signs and symptoms. Usually think potassium and sodium when you think chloride. It's going to be, those are going to be out of balance with chloride. Patient education, obviously avoidance of those high chloremic foods. Don't forget like processed meats and stuff. Canned vegetables can have a lot of salt. Bananas have a lot of potassium. Cheese, milk. And we're going to limit our intake of free water. Free water just means water without electrolytes. We're limiting intake of free water because we don't want a concentration problem. Okay. Here is our slide. Slide 40 is hypochloremia compared to hyperchloremia. So you can see those side by side. Phosphate. All right. So phosphate, most abundant intracellular anion. Phosphate in the ECF is known as phosphorus. Most phosphorus in the body is combined with oxygen, forming phosphate. So phosphate is just phosphorus and oxygen. It's mostly bound with calcium in the teeth and bones as calcium phosphate. All right. So calcium and phosphorus work together. So phosphorus primarily, oh, I just said that, sorry. They are in an inverse relationship with each other though, phosphorus and calcium. You can also find some inside the cells. Let's see. Phosphorus levels maintained with dietary intake and renal excretion. Hypophosphatemia. So clinical manifestations appear only when phosphorus levels are less than 1 milligram per deciliter. Hypophosphatemia results from decreased dietary intake, decreased intestinal absorption, maybe increased renal excretion. It can be related to shifts from the intracellular space to extracellular, and that results in urinary loss. In respiratory alkalosis, phosphate shifts into the cell and is used for intracellular glycolysis, leading to phosphorus consumption. Signs and symptoms. Neuro, cardiac, musculoskeletal function, confusion, apprehension, seizures, coma. Those are our neuro symptoms. Most often, if you have hypophosphatemia, you're going to see that smooth muscle weakness. Clinical manifestations may also kind of include tremor, paresthesia, joint stiffness, and bone pain. So it's similar to what we see related to calcium, right? So when you think of this phosphorus, which we aren't thinking about phosphorus if we're not thinking about calcium, so those signs and symptoms are going to be similar. So treatment, we're going to want to treat underlying causes, and we always think of other electrolyte disturbances related to this. So not uncommon that we're going to have hypokalemia, hypomagnesemia, and hypocalcemia. All right. So as we treat those, which are by far the more important electrolytes to treat, you're going to see the shift in your phosphorus, because the mechanisms of action are going to pull the phosphorus levels along with them as we treat the hypokalemia, hypomagnesemia, and or hypocalcemia. Okay. Let me see if there's anything else crazy on here. Not really. Our RN considerations, we're going to think about our chronic alcohol abuse people, our diabetic ketoacidosis people. They're going to be treated with insulin. Our DKA people who were treated with insulin puts us at risk for hypophosphatemia. Critical illness because of malnourishment, excessive burns. What we're going to do is treat the underlying causes and replace the other electrolytes. Hyperphosphatemia, this is really related to renal failure. Similar to those seen, our signs and symptoms are going to be like hypocalcemia because of the inverse relationship of phosphorus and calcium, right? If we have hypocalcemia, we would expect to have hyperphosphatemia a lot of times. It depends on why we have hypocalcemia though. Treatment, treat the underlying cause, right? If we have renal failure, maybe we are looking at Diuretics, maybe we are looking at dialysis. Complications are going to be the things we see related to hypocalcemia, so like tetany, long-term related to calcification and atherosclerosis is a problem. Our considerations, dietary intake, and the inverse relationship with hypocalcemia. Here is your slide 44. This is hypo versus hyperphosphatemia. Just take a look at that. Notice with hyperphosphatemia, you can have the positive Chavostecs and Trousseaus because of that inverse relationship with calcium. So we get positive Chavostecs and Trousseaus and hypocalcemia, too little calcium. We're getting all that twitching and muscles are not being kept in check, right? So with hyperphosphatemia, you can see positive Chavostecs and Trousseaus, but know that that is related to the hypocalcemic state that the body is also in, all right? So definitely when you see positive Chavostecs and Trousseaus, think hypocalcemia, not hyperphosphatemia, because nobody's caring about phosphorus. All right, we're going to move on to Chapter 9, Acid-Base Balance. Okay, so acid-base balance refers to the homeostasis of the hydrogen ion concentration in body fluids. So hydrogen ions are positively charged, all right? Remember, we are electricity. So the body's fluid concentration of hydrogen ions is expressed as the body's pH level. So when we say pH, what we're talking about is the hydrogen ions, okay? So body fluids are further classified as acids or bases according to the hydrogen ion concentration. Hydrogen ion concentration of body fluids is vital to acid-base balance. Hydrogen ion concentration is measured in terms of pH. The pH numerical value is inversely proportional to the number of hydrogen ions in the body fluid. So, as hydrogen ion concentration increases, pH decreases, and that is it becoming more acidic. As hydrogen ion concentration decreases, pH increases because it's becoming more basic, okay? So hydrogen ions cause our acidity. And remember, the body has a very narrow pH balance, 7.35 to 7.45. That's 0.1 of a difference, right? We don't have a whole lot of range, okay? So just keep that in mind. If there are fatal pH levels less than 6.8 and greater than 7.8, right? So going either direction, whether we become more acidic to the point of 6.8 or more basic, greater than 7.8, it can lead to death, all right? So we really, we have a narrow range there and we need to keep it in balance. Really with acid base is all about the body trying to keep this pH in balance. All right, that's all it's doing. And it's using those hydrogen ions to do that, okay? All right, so acids. So acids are hydrogen ion donors, okay? Hydrogen ions are acidic in nature, so an acidic solution is going to have more hydrogen ions and a pH of less than 7.35, all right? That's going to make us more acidic. The excess of hydrogen ions can be a result of overproduction of acids that causes the release of hydrogen ions, or an under-elimination of acids that causes retention of hydrogen ions. Because hydrogen ions are positively charged, hydrogen ion excess in the blood causes imbalances in other electrolytes, such as calcium, potassium, and sodium. Remember, they are positively and negatively charged as well, right? Everything's electricity. So these imbalances can lead to disorders of the cardiac, central nervous, and neuromuscular systems, and respiratory. So in the body, think of CO2 in the respiratory system as our acid, all right? CO2 is the acid component when we're talking ABGs. So it forms H2CO3, which is carbonic acid, and notice that it utilizes 2 hydrogen ions there, all right? And hydrogen ions are acidic, CO2 is acidic. CO2 is exhaled by the respiratory system. When the body holds on to CO2, the body runs the risk of becoming acidotic, too much acid. So you're going to see this in disease processes like COPD and even asthma, where our problem is getting CO2 out. It's not getting O2 in. Our problem is not getting O2 in. Our problem is getting CO2 out, right? So that can put you into an acidotic state. Now, our bases are known as hydrogen ion acceptors. A base or alkaline, we call this also alkalosis, that refers to your base. And remember from chem, acids and bases cancel each other, right? So that's why we're always talking about homeostasis and this back and forth. Acids and bases keep each other in check in a state of homeostasis. So a base or an alkaline solution has fewer hydrogen ions and a pH of greater than 7.45. So it's more basic, less acidic. Alkalosis can result from either an overproduction of base or an underelimination of base. The most common base is bicarb, and the systems affected are cardiovascular, muscular, and nervous systems. Remember, because bicarb is going to affect how all those electrolytes that positively charge our muscles and cause our muscles to move, but also not overreact, right? It's going to cancel that out. So compensation. So compensation, all this means, all right, so I've got the respiratory system working on my acid, which with my CO2. I've got my kidneys working on my bicarb, right? My base. Everything's keeping itself in check. What happens when stuff gets out of whack? Like let's say I have COPD and my CO2 is just off the charts. I'm retaining way too much CO2. So what happens is my kidneys are like, I can help you out. I can produce more bicarb that is going to neutralize that acid. So compensation is where one system kicks in to help the other system. All right? Partial compensation is when my pH level is still not within range, and one system is working super hard to balance out the other. All right, that's partial compensation. So partial compensation means, either the kidneys or the respiratory system, they're working real hard to get everything in balance, but my pH is not quite back in range yet. Now, full compensation is when the two systems have worked hard enough to get that pH back within normal levels. The problem is, though, your CO2 and your bicarb gonna be out of range because your systems are working super hard to keep that pH in balance. So you are still at risk of system failure because it's not, even though your pH is within range, your body is struggling to keep it there. So anytime we are struggling to keep something in homeostasis, technically we're not really in homeostasis because the body shouldn't be struggling, and it's going to take wear and tear, and something's going to give out. All right. So now this is talking about measuring ABGs. An ABG is an arterial blood gas. So we take the blood from an artery versus normally we get a vein, right? So this is from an artery, so it's oxygenated blood. PaO2 measures the partial pressure of oxygen in the arterial blood. It's the most important factor in determining how oxygen is binding to the hemoglobin. Um, if the PaO2 is high, more oxygen is able to bind with the hemoglobin. If PaO2 is low, there's less oxygen to bind with hemoglobin. The SaO2 is what we measure on your pulse ox, right? That's the oxygen carrying capacity of the hemoglobin, and that uses the pulse ox. And that's good. That's perfectly fine telling us where our O2 is at, all right? But that doesn't tell us about our acid-base balance. So our PaO2 is the O2 that we look at related to acid-base balance, all right? Um, ABGs are also going to look at PaCO2, our bicarb, that's that HCO3, and then of course our acid level. So ABGs, they tell us if our acid-base imbalance is uncompensated, partial, compensated, or fully compensated. All right. And this is what we're going to go over figuring out in class, in lab. So CO2 and respiratory. So this talks about like respiratory buffers basically. And buffers are just other things in the system that help keep this bicarb and CO2 in check. It just kind of helps the process along. So any retention of CO2 or increase in the body's concentration of CO2 produces an increase in hydrogen ions through the generation of carbonic acid. That's that H2CO3, right? So this is going to lower the pH, so more acidic, and thus promotes the development of an acidotic state, which is observed in conditions such as COPD. While in the acidotic state, chemoreceptors in the brain respond to the increased CO2 levels by stimulating the respiratory system to increase the respiratory rate and depth in an effort to excrete CO2 through the lungs. Conversely, decreases in CO2 concentration result in decrease in hydrogen ions. This leads to a pH rise, which means I'm getting more basic or an alkalotic state. So when I have too much CO2, my body is going to want me to blow off that CO2. So I'm going to be like, because I'm trying to get that CO2 out. I can't even take in more O2. It's not going to sit on the receptors if I have too much CO2 because CO2 and O2 occupy the same receptors, all right? So my body's going to have me try to blow off that CO2 as like step one. So respiratory acidosis is the primary acid-base imbalance, resulting from decreased rate and or depth of respirations leading to CO2 retention. Characterized by a low pH, so more acidic, and elevated CO2 levels due to the alveolar hypoventilation. Remember, our alveoli are supposed to be pushing, there are little flexible grapes. They're supposed to be pushing out that CO2. If they are hyper or hypoventilated, right? They're not as flexible as they should be, and they are not adequately pushing out that CO2. So that CO2 is just sitting in there, being an acid, causing me to become acidotic. All right? So what the body is going to do is the kidneys are going to produce more bicarb, which is going to help um, neutralize that acidotic state. All right. This is a really important slide. Slide 53. This is box 9.2 and box 9.3. This is causes of respiratory acidosis. and clinical manifestations of respiratory acidosis. So respiratory acidosis, my person is holding on to too much CO2, okay? Period. That's all that is. And then those are my signs and symptoms. So our treatment, respiratory acidosis, um, let's see, treatment, bronchodilators to open constricted airways. We're going to want to try to give oxygen, medications to treat hyperkalemia because they can be in a hyperkalemic state likely. If there's an infection, antibiotics, chest physiotherapy, help move those secretions so my person can breathe better and therefore exchange that CO2 more effectively. And then if there's anything blocking the airway, maybe my person has increase of CO2 because they have an obstruction in the airway and are not adequately ventilating, right? We can also do a chest tube, which is going to help with lung expansion. If there's drainage, get any drainage out of there, which is going to help. And possibly intubation and mechanical ventilation, depending upon how bad the problem is. I shouldn't say how poor, how bad the problem is. Possible non-respiratory treatments, reversal of sedation. Maybe my person has respiratory depression related to too much sedation. Maybe my person has heart failure and now there's fluid in the lungs. So I'm going to want to treat the heart failure, maybe use some diuretics, get that fluid out of there. Respiratory acidosis RN considerations. We're going to be looking, of course, all of our vitals, our pulse ox, signs and symptoms of respiratory acidosis. CO2 buildup in the lungs. People get a really bizarre confusion. They're going to be like, look at that purple cow on the ceiling. It's not like dementia where they just don't know what day or year or think Reagan is still president sort of thing. CO2 buildup is loopy, right? And it really is. They're gonna say crazy things I don't know, like a purple cow on the ceiling, right? Just crazy loopy things. Interventions, we're gonna want to maintain that airway. We're going to monitor those ABGs. And vitals, O2, calming environment, reassurance. Our person is going to feel like they can't breathe. So they're going to be restless, anxious. And like we talked about before, if you're restless and anxious, that affects your breathing as well. So we need to keep calm. Complications can be paralysis, coma, related to prolonged increased CO2. And that's because of cerebral vasodilation. Anytime our brain gets involved, problem, right? All right, respiratory alkalosis. So now I'm becoming too basic. So respiratory alkalosis is an acid-base imbalance caused by an increase in the rate of alveolar ventilation. Acute alveolar hyperventilation is frequently the result of anxiety and is commonly referred to as hyperventilation syndrome. So now I'm panting, right? And I'm causing my body to blow off too much CO2 when I shouldn't be, right? I should be breathing nice and easy. So this is going to blow off too much CO2. And now I'm going to be too basic. All right. So the body tries to restore the pH to normal levels through renal compensation. In this process, renal excretion of bicarb is increased. Respiratory alkalosis may be acute, resulting from hyperventilation, or chronic, which can be difficult to identify because of the renal compensation. Patients in the early stage of pulmonary edema may present with respiratory alkalosis due to the increased respiratory rate, secondary to anxiety and hyperventilation associated with attempts to increase oxygenation. Causes of respiratory alkalosis there are listed in 9.4 and are associated with increased ventilation, leading to excessive CO2 excretion. So now notice how she's breathing into a paper bag. So if I am hyperventilating, The reason you blow into a paper bag and breathe back in is because if I'm hyperventilating into my paper bag, when I breathe back in, I'm going to breathe back in that CO2, which is what I need to do. I need to balance back out that CO2. So here's our box 9.4 and 9.5. These are our causes of respiratory alkalosis and our clinical manifestations. Our nursing considerations, we're going to be watching our O2, our ABGs. We're going to try to calm our person down. Our person's going to feel lightheaded, so we're going to worry about falls. Related to the lightheadedness, they may be kind of confused. This is not a person you want walking to the restroom on their own. Interventions, slow, deep breathing. Breathing into that paper bag because we re-intake that CO2. Complications, you can actually result in seizures. You may have chest pain because you're hyperventilating, you're breathing so hard. So really the biggest thing is calming that person down, all right? All right, now we're on to bicarb and the renal system. So bicarb is released by the kidneys, but it is the slowest acting buffer system. All right, if the body is alkalotic, which is too much base, the kidneys excrete the bicarb and reabsorb the hydrogen, which is an acid, and release in urine the CO3, resulting in an alkalotic urine. Okay, so it produces it alkalotic, so we have too much base. So the body actually releases bicarb, which is a base, reabsorbs the acid, which is the hydrogen, and then flushes the rest of the CO3, which is basic. All right? So, and then if the body is an acidotic state, which is too much acid, the body excretes the hydrogen ions, so pees out the hydrogen, and reabsorbs the base. So then our urine is going to be more acidic because we're getting rid of all these hydrogen ions, right? Response can begin within hours, but it really takes days to like fully compensate. So metabolic acidosis, so we have increased hydrogen ions. So this can be related to a decrease in bicarb, right? So this can be our DKA, our diabetic ketoacidosis, our lactic acidosis. Lactic acidosis happens related to muscle breakdown and obviously well, not obviously, but lactose is an acid, so lactic acidosis. So if you've like run a marathon or you worked out extra hard and you have a lot of muscle breakdown, you can end up with a metabolic acidotic state because of the muscle breakdown. Diarrhea, we poop out bases for the most part. So with severe diarrhea, you've pooped out those bases and those acids have stayed. Severe GI malabsorption and acute or chronic renal failure. The body's going to try to compensate by stimulating respirations and decrease CO2 levels. So again, we're in metabolic acidosis. So even though we're kind of talking about the kidneys, CO2 is still our acid. We're going to try to get rid of that. The body may also pump out some potassium to absorb the hydrogen. The problem is you are at risk then for hyperkalemia, and then we're going to have all those signs and symptoms of hyperkalemia. So you got to take that into consideration. This is a safety alert. This is slide 61. In patients with metabolic acidosis related to hyperglycemia, potassium is moved outside the cell in exchange for hydrogen ions and may be excreted due to the osmotic diureses associated with DKA, diabetic ketoacidosis. As the elevated blood glucose levels are normalized and acidosis resolves, potassium moves back into the cells and the patient must then be monitored for hypokalemia. All right. So again, think about this back and forth, right? As the body, my daughter always says that like the body is trying to help out, but usually causes more of a problem. This is kind of one of those things, right? It releases some potassium to grab those hydrogen ions, but then you end up in hyperkalemia, right? Which is not good. We can end up with those EKG changes and all of that craziness. And then, though, as we resolve the DKA, when we're particularly talking about DKA or whatever the state, the acidotic state may be, as it normalizes, right? Then our potassium's like, oh, you don't need me anymore, and goes all back into the cells. And now we run the risk of hypokalemia. Okay, so this is why your ICU patients are 1-to-1, right? Because think of all this back and forth and the careful monitoring we need to do, because as soon as we tip into a different state, you take on all the problems that come with that state. All right? All right, metabolic acidotic treatment, dependent on underlying cause. So sodium bicarb replacement administered IV neutralizes blood acidity in patients with a pH lower than 7.1. Rapid acting insulin may be needed for patients with diabetes in order to reverse the DKA and drive potassium back into the cells. Antidiarrheals, if your person has bicarb loss related to diarrhea, remember we poop out bases. When we vomit, it's acids, right? Vomit is coming from the gut, which is acids in the gut. By the time we have diarrhea, we're pooping out bases, we're vomiting out acids. Dialysis may be needed, and your person may need mechanical ventilation to assist with respiratory compensation. This is box 9.6, causes of metabolic acidosis, and box 9.7, which is our clinical manifestations of metabolic acidosis. So definitely want to be aware of these. All right, metabolic acidosis are in considerations. DKA. DKA is really our biggest thing. And then people can have metabolic acidosis related to starvation, like we talked about diarrhea, trauma shock, renal failure. Our problems, cardiac output, so heart, dehydration, fluid imbalance, acute confusion, and anxiety. Our interventions are going to be treating that underlying cause and administering bicarb as ordered. Complications, if that pH goes below 7, we worry about dysrhythmias. And so obviously our person's going to be on monitoring. Metabolic alkalosis. So alkalosis, basic. So this is caused by an increased loss of acid. This can be our vomiting. This can be our NG suctioning. It can be renal secretion. The body uses hypoventilation to compensate. So the body's going to try to hold on to that CO2. So serum potassium pumped into the cell pumps into the cell, releasing hydrogen ions, which raises the acidity. Okay, so again, we're using the potassium to help with this imbalance. So box slide 66, box 9.8 and 9.9, those are our causes of metabolic acidosis and then our clinical manifestations. Please take a look at that. Metabolic alkalosis treatment, as usual, dependent on the underlying cause. If my person is on potassium wasting diuretics, I'm going to stop those. If I am doing any NG suctioning, I'm going to stop that. I want the body to hold on to that acid. I don't want to pull that acid out. If my person has vomiting or even nausea, I'm going to use an antiemetic. You can actually use acetylzolamide, which increases renal excretion of bicarb if patient is not hypovolemic or hypokalemic. Okay, so again, When we have these acid-base imbalances, we have to look at what else is going on with our person. Is it related to hypovolemia or hypervolemia? What other electrolyte imbalances do they have going on? And what electrolyte imbalances do I risk causing because of my treatment, right? You have to keep all of that in mind because that's all the stuff you're going to be monitoring for. Metabolic alkalosis RN considerations, assess for vomiting, gastric suction, PUD. Priority problems, decreased cardiac output related to electrolyte imbalances. And then with those electrolyte imbalances, we can have confusion. So with confusion comes risk of falls, all that sort of thing. Safety, right? We want to think safety. So interventions related to underlying cause, maybe IV fluids, complications. Don't forget our pH levels and dysrhythmias and comas, problems related to that acid being off. This is slide 69, table 9.2 and 9.3. 9.2 talks about the respiratory system, the role it plays in acid-base imbalance, and then it compares it to the renal system. All right, so this is a really nice slide. I love having all these tables next to each other so that you can really compare and contrast what is affecting what. All right, so that is acid-base balance and electrolytes. We are going to spend a lot of time on this in class. We get a full week for electrolytes and we get a full lab for ABGs. So don't panic about any of this. We're going to be going over it all. Thank you.